optimization of antibiotic practices. Introduction. Antibiotics are reported to be the second most frequently prescribed class of pharmaceuticals. Approximately 40% of hospitalized patients receive an antibiotic during the inpatient stay. There are a number of reasons that antibacterial prescription may be considered inappropriate. These include the absence of a bacterial infection or an indication for prophylaxis, or in a violation of one or more of the following 3 S's of optimal antibiotic therapy: the right drug, the right dose, the best route of delivery, attention to the de-escalation, and the appropriate duration of administration. Antibiotics are a precious resource. Antimicrobial stewardship is an approach to improve patient care and sustainable antibiotic use. Definition. Antimicrobial stewardship refers to coordinate interventions designed to improve and measure the appropriate use of antimicrobial agents by promoting the selection of the optimal antibiotic drug regimens, including dosing, duration of the therapy, and route of administration.
Fast forward to the 21st century, and the chief doctor in the UK calls for antimicrobial resistance to be put on the National Risk Register and be taken seriously. And the US government describes antimicrobial resistance as one of our most serious health threats. In Canada, outbreaks of superbugs frequently make headlines because they kill patients. Antimicrobial resistance isn't a new phenomenon. All germs have the ability to develop resistance. But the more drug exposure there is, the faster resistance develops in people, animals, and agriculture. We now face infections that are resistant to many, if not all, of our available drugs, and there is very little to look forward to in the antibiotic development pipeline. Since 2010, only 3 new antimicrobials have been approved for use in Canada. This means that we must manage these precious resources more wisely, like preserving clean drinking water or halting global warming. Inappropriate or unnecessary use of antimicrobials is often cited as up to 50%. Misuse of antimicrobials is risky to patients. It can increase mortality, time spent in hospital, and lead to collateral damage, such as a new infection with another bug, like C. difficile, a germ that causes diarrhea in most, but may cause serious or fatal infection in others. Using antimicrobials appropriately will not only help preserve our antibiotics, but will also improve patient outcomes and patient safety. Everyone wants to do the best thing for their patient. Sometimes that feels like wanting to give the strongest, broadest spectrum antibiotic. But we need to ask, is that really the best thing, not just for this patient, but the patients in the global community? We need to carefully think about why we are giving the antibiotic, what drug to choose, and how we're using it. Dose, duration of therapy. We are falling behind the curve with the prevalence of multi-drug resistant organisms and the lack of new, innovative antimicrobials. Antimicrobial stewardship is just one facet in the efforts to improve outcomes among patients with infections and reduce the incidence of resistance. Everyone plays an important role as good antimicrobial stewards.
Objectives. The major objectives of antimicrobial stewardship are to achieve best clinical outcomes related to antimicrobial use, while minimizing toxicity and other adverse effects, thereby limiting the selective pressure of bacterial populations that drive the emergence of antimicrobial resistance strains. Antimicrobial stewardship may also reduce excessive costs attributable to suboptimal antimicrobial use. The story of penicillin. Penicillin was discovered by bacteriologist Alexander Fleming working at St. Mary's Hospital in London in 1928. He observed that a plate culture of Staphylococcus had been contaminated by a blue-green mold and that columns of bacterial adjacent to the mold were being dissolved. Curious, Alexander Fleming reviewed the mold in a pure culture and found that it produced a substance that killed a number of disease-causing bacteria, naming the substance penicillin. Dr. Fleming, in 1929, published the results of his investigations, noting that his discovery might have therapeutic value if it could be produced in quantity.
Fleming's work, however, proved invaluable. In 1935, scientists Albert Flory and Ernst Chain at Oxford University came across a record of Fleming's curious but incomplete work with penicillin and decided to investigate. This time they successfully extracted and purified penicillin. And in 1940, they tested it. They injected 8 mice with lethal doses of the bacteria Streptococci. Then they injected 4 of the mice with penicillin. Within hours,
Principles of antimicrobial use. Important considerations when prescribing an antimicrobial therapy include obtaining an accurate diagnosis of infection, understanding the difference between empiric and phonetic therapy, identifying opportunities to switch to narrow-spectrum, cost-effective oral agents for the shortest duration necessary, understanding drug characteristics that are peculiar to antimicrobial agents, accounting for host characteristics that influence antimicrobial activity, and in turn recognizing the adverse effects of antimicrobial agents on the host. It is also important to understand the importance of antimicrobial stewardship, to know when to consult infectious disease specialists for guidance, and to be able to identify situations when antimicrobial therapy is not needed. By following these general principles, all practicing physicians should be able to use antimicrobial agents in a responsible manner that benefits both the individual patient and the community. Prophylactic. To prevent the infection. Example of patients' prevention of endocarditis at-risk patients undergoing at-high-risk dental producers. In patients, surgical prophylaxis. Preemptive. To avoid the infection. Ensalming. Cytomegalovirus infection in immunosuppressor transplant recipients. Empiric. To provide initial control of the infection. Example, all patients acute sinusitis, community-acquired pneumonia, urinary tract infection. In patients, community and hospital-acquired pneumonia, fever, and neutropenia on different sepsis. Definitive. It is to cure infection of known etiology. Example, any infection in which the etiologic pathogen and its antimicrobial susceptibility is known. Empiric therapy in sepsis. An important element is choosing the appropriate antibiotic or antibiotics to administer. That antibiotic must be administered as rapidly as possible. Another important element in deciding which antibiotic or antibiotics choose empirically include the site of infection and the likelihood of antibiotic resistance. Principles of antibacterial pharmacokinetics and pharmacodynamics. The goal of antimicrobial therapy is the effective, efficient, and safe treatment of patients suffering from infections. The pharmacodynamics of an antimicrobial drug related its pharmacokinetics to the time course of the antimicrobial effects at the site of infection. Knowledge of the drug's antimicrobial pharmacodynamic effects provides a more rational basis for determination of optimal dosing regimens in terms of the dose and the dosing interval that do the minimal inhibitory concentrations and minimal bacterial concentrations determined in vitro. Pharmacokinetics. It is what the body does to the drug. It includes its absorption, distribution, metabolism, and elimination of the antibiotic. Pharmacodynamics is what the drug does to the body. It examines the relationship between the measured drug concentration in the serum, tissue, and body fluid and its antimicrobial effect on the target organism. The effect of the antibiotic could be bacterial killing or inhibition of growth. Pharmacodynamic properties can be used to divide antibiotics into Major classes based on their mechanism of bactericidal action. Concentration-dependent drugs such as aminoglycosides and fluoroquinolones, and concentration-independent drugs, including the beta-lactams. Antibiotics also differ in the post-antibiotic effect that they exert. In general, concentration-dependent drugs have a more prolonged TAE than concentration-independent drugs, particularly against Gram-negative pathogens. High drug levels should be the goal of the therapy. Concentrations of antibiotics that are sublethal can permit the emergence of resistant pathogens. Optimization of antibiotic regimens on the basis of pharmacodynamic principles could thus significantly diminish the emergence of antibiotic resistance. Now another video about antibiotics. resistance. Antimicrobial resistance (AMR) is resistance of a microorganism to an antimicrobial drug that was originally effective for treatment of infections caused by it. The evolution of resistant strains is a natural phenomenon that occurs when microorganisms replicate themselves erroneously or when resistant traits are exchanged between them. The use and misuse of antimicrobial drugs accelerates the emergence of drug-resistant strains. Poor infection control practices, inadequate sanitary conditions, and inappropriate food handling encourage the further spread of AMR. With bacterial skin and skin structure infections. We have cellulitis, that is a common bacterial skin infection. It may first appear as a red swollen area that feels hot and tender to the touch. The redness and swelling often spread rapidly. Cellulitis is usually painful. Number 2 is abscess. It is are typically caused by either an inflammatory reaction to an infectious process, bacteria or parasites. Erysipelas is a type of cellulitis that is characterized by the presence of a well-defined and often red border. The conclusion. At a congressional briefing in September 2013, spoke to Congress of the need for them to take a number of actions to combat the problem of antibiotic resistance. In their report, CDC recommends several core actions aimed at stopping the spread of antibiotic resistance. Among these is the improvement in the way antibiotics are used. That is the same goal as that of antimicrobial stewardship. An effective antimicrobial stewardship program must be based on the clinical sciences of antibiotic use and the application of principles that aim the achievement the optimum balance in patient care, both for the individual patient and for every patient to follow.